Thank you to the American College of Medical Quality. We continue on our educational series, and today we're going to hear about how to maintain quality during organizational change. I'm Andrea Restifo. I'm Associate Executive Director for Quality and Safety at North Shore University Hospital, part of Northwell's Health System. I'm here today at Cohen's Children's Medical Center, where they're going to talk about how they had a tridemic post-COVID and how they managed during that. With me today is Dr. Fiona Levy, the Medical Director and the Vice President of the Pediatric Service Line, and also a professor at the Zucker School of Medicine at Hofstra Northwell. Next to her is Kim Stagg, who is the Director of Financial Operations. And next to Kim is Linda Jendresky, who is the Associate Executive Director for Quality and Safety here at the Children's Hospital. Next, we welcome Brian Belcano, who is the Associate Executive Director of Operations. And next to me, on my left, is Margaret Duffy, our Associate Executive Director of Patient Care Services, and as well as our Chief Nursing Officer for the Children's Hospital. On my right side is my partner in crime, Dr. Yosef Tolugash, who is a retired Senior Vice President for Quality here at Northwell, a trustee at Northwell, a member of the Board of the American College of Medical Quality, a professor and executive in residence at the Hofstra School of Business, which is located close to this campus. So we're really excited to be here today. The goal of the talk is to understand how Cohen's navigated through this external challenge while maintaining and sustaining operational efficiency and quality of care, and how they use the Incident Command Center here to take care of the children at this hospital and in the area. I'll turn it over to Yosef to go over some of the points today.
Good afternoon to all. The most difficult part during change is how to maintain sanity, how to maintain operation without going into or facing new crises as you fix one crisis. And also at the same time, how do you maintain quality? Typically in time of peace or lack of crisis, quality becomes a routine. It's part of the operation. But during crisis, all of a sudden, it's being on the back seat of the situation. So how do you maintain it? How do you bring it to the forefront? So what we'll see today and hear from executives at Cohen Children's Hospital, how they did it. We'll talk about the role of the leadership and what does it mean to respond to crisis and how flexible they were during this type of crisis, because rigidity doesn't help. Rigidity creates situation that from the past, which in the future and the present, create new crises. So how flexible were they in terms of responding to this situation? And then they will explain to us through a structure that they developed here and a process called Incident Command Structure and what they did during this situation. Also, as you remember from my previous presentations, data is extremely important. Without formal information, without analysis, we really cannot cope with crisis. And I'm really looking forward to this presentation because in the past, we always try to bring finance into different presentation. And today we have a very nice surprise to show how finance use data and quality in terms of making the appropriate changes during those crises. So without any other introduction, We go to the next slide. We'll be talking about the scope of Cohen Children's Hospital.
Well, Yosef, thank you for the opportunity to come and join you and to share our story. And I'll tell you a little bit about Cohen Children's Medical Center. I think the first thing I'd like to say, though, is we are blessed by a really wonderful group of leaders. We get along, we respect each other's expertise, and I think what was so important during this challenge that we're going to describe was that we maintained our sense of humor and camaraderie, which I think was crucial to our success. So Cohen Children's Medical Center is really the flagship children's hospital for our health system, Northwell Health. We're a 195-bed teaching hospital. We are an inaugural member of an international consortium of children's hospitals that work together to address patient safety and to eliminate preventable harm for children. And this membership, I think, was really important during this triple-demic and beyond, because it allows us access to many of our colleague children's hospitals, and we have a long history of sharing data, sharing challenges, and sharing solutions and expertise. We also have a number of key programs that make us really a delivery of quaternary care. They include a robust trauma program with certification, a program for extracorporeal membrane oxygenation, which again differentiates us as a children's hospital, and we have a solid organ transplant program as well. Something else that we're very proud of and that really came into play during this triple-demic was we have a robust transport service that allows us to move children, critically ill children, safely among the hospitals within Northwell, but as importantly, also to bring children from non-Northwell facilities in for care at Cohen Children's Hospital. And this service was very busy throughout the triple-demic. So I believe I'm going to turn this over back to you.
Thank you very much. This is a very thorough analysis of the scope of care. And of course, as you spoke, there are many questions that came up in my mind, but I'll leave it for later on. So we are trying to focus on a particular crisis, a particular phenomenon that took place at Cohen's Hospital. So in terms of defining the problem, for the sake of the presentation, we gave one example of respiratory illness. So to define the problem, to be, if you can answer a couple of questions. One is that what was the respiratory issue in the number of children that were impacted by this type of a disease, and really what does it mean? Because respiratory illnesses, cannot say it's a common phenomenon, but it occurs in every situation. But what was unique to this situation that we can define it as a crisis? And second is what happened. What happened, really, basically, in a very simple word. And then when it did take place and how long and for how long.
So if we go to the next slide, typically in the world of children's health, we're very used to the fall bringing an increase in viral illness, particularly respiratory viral illness. What was unique about the fall of 2022 was that where we normally see children coming in with an infection from something called respiratory syncytial virus, or RSV, we were also seeing a high number of children coming in with COVID and with influenza. And often children, particularly the youngest children, were infected with more than one virus. We think that this has something to do with the fact that during the COVID pandemic, many children were staying at home, and so they weren't exposed to other children, and probably they were now seeing these viruses for the first time, making them susceptible to the virus and to the severity of illness. So again, what made this fall winter unique was the triple-demic of 3 types of viral infections, and also that we saw a disproportionate effect on young children and a really increased severity of illness. And that was important because it not only led to increased numbers of patients seeking care, but those that sought care had a much higher proportion of requiring critical care, placing a huge burden on our ICU services. It has also stressed a number of the community hospitals that are part of our referral base because they really are not prepared, both in expertise or in space, to care for a number of critically ill children. And so we saw ourselves really providing a support network for all of the hospitals within our community. I think we were proud of the work that we did during this time. We worked very hard to accommodate any request for transfer to Cohen Children's or to pediatric services within Northwell Health. And I think you could probably count on 1 or 2 hands the number of children who we had to decline a transfer for. So this was really the crisis that was set up for us to manage in the fall of 22 and through the winter of 23.
And logistically, during this time frame, we were coming out of the COVID pandemic. So as everyone knows, this COVID was, although we did have children who were affected by COVID, both on med-surg and in the ICU, but largely this was affected the adults. So we had not replenished many of our staff during this time. We had spent, as our volume came back and our acuity increased, we were in the process of hiring and training, but then this triple-demic hit. So we were faced with a staff that was not completely prepared from a volume and experience standpoint to handle this, so we had to assemble very quickly as a team to provide what was the support that we needed. We relied heavily on our education team to help train very quickly, do some just-in-time training, and to really be able to face this from a nursing perspective and a general personnel perspective. Unique here, during COVID, our adult colleagues stopped surgical services, procedural services. We kept all of our services going, in addition to having this large volume of acuity coming in at this time. So we kept all of our services open, which made it also very challenging.
So really, to summarize it, if I had to define the problem, it's really you're overwhelmed with the severity of illness, you're overwhelmed with the census, you're overwhelmed with the level of care, because now you have to train people who are adult in pediatric, basically.
Correct.
And as we discussed in the past, the communication is very different between a child patient and an adult patient. All of this had to be really part of the situation. So thank you very much. So as you mentioned, in terms of the structure, you created a command center. And how do different roles help in the command center and business continuity? This is one question. And the second, describe how the resources were managed at the same time.
Yeah, thanks, Joseph. So anytime there's an incident or an emergency or any event that's going to tax resources out of the hospital, we implement our incident command system. This system is really taken from the national NIMS programs that the government puts out as training for us. And it allows us to create a flexible structure of leadership that provides coverage to all different areas of the event or emergency. And these emergencies can be weather events, they can be power outages. In this case, it was an influx of patients, of pediatric patients. And being part of Northwell Health, allows us to tap into a lot of the resources within the health system to build this structure. But it also means that we have to maintain our regular business besides the surge. And so when we created the incident command structure, the first thing we did was made a decision at a leadership level that we were going to split some of our leaders off and to maintain regular business. And so those leaders took the projects, took the tasks of the leaders who were going to be part of the structure and ran with them for that time period. And then everyone else was dedicated to this structure. So I had the privilege of serving as the incident commander during the event. We had our operations leaders, Peg and Fiona. We had our logistics leaders, which are some of the operations people who work for me. Kim ran our planning section, along with the finance section, and we were really able to create a day-to-day process where we were able to review what was happening within the hospital as it related back to the surge. And so some of the daily tasks that we did where every morning the leadership team would meet with our executive director and executive cabinet. We would discuss what was going to happen for the rest of the day, discuss updates that were happening overnight, and really set the plan for what was going to happen at the remainder of our meetings that happened all day long. The next meeting really was with more of our operational leaders to get situational status of what was happening. We then met with our corporate resources that helped us bring things in that we needed, take things out that we didn't need, and then we continued to meet throughout the day to get updates on the volume that was coming in. In pediatrics, kids and parents, they don't tend to come in a level, load across the day, right? Parents are done from work, kids are out of school, and now everybody kind of shows up in the evening or after work. And so there was definitely a heightened awareness of the volume of children that were coming into our emergency department overnight. And that's where our leadership team, our clinical leadership team, really took an active role in providing leadership grounding in the overnights.
Right, exactly. And this was not something that was done Monday through Friday. So children didn't stop coming in Friday afternoon. So this was something that we needed to set up as a sustainable model, not knowing really how long this was going to be going on. So that where Kim and her team finance were very important in the predictability and the forecasting in this. But we set up this structure. We did it every day. There were some holidays sprinkled throughout this experience. Sometimes on the weekends we modified it a little bit, but we had coverage 7 days a week. And as we told our leaders, this is going to be a marathon. This is not going to be a sprint. So we didn't want to go in extremely hard and fatigue everyone. So making sure that there were schedules that were created. Fiona and I were the leaders on the clinical side. We set up a physician nursing rounding schedule of senior nurse and senior physician leaders who would come in on the off shift to make sure that these new team members, both at physician, nursing, respiratory therapy that we had to get in here, were supported on the off shift and making sure that they had what they needed to have. And we removed barriers. If things weren't moving along quickly, if something as simple as somebody took a break on one unit and it was holding up getting discharges, we were able to help mitigate some of those factors. So the 24-hour nature of it was extremely important in 7 days a week.
I think it made us credible too.
Right.
As leaders, that we weren't just giving instructions as to what to do, we were trying to walk the walk with our colleagues.
Yeah. I was going to say, Peg mentioned data, and one of the most, to me, important pieces of data that we had was this historical volume and then trends that we saw in the rest of the country thanks to our relationship with other children's hospitals. This allowed us to bring some data together, and Kim and her team created a predictive model, actually, to try to forecast what we were going to need. So, Kim, maybe you can tell us a little bit about that model.
Yeah, so I think we knew that we were experiencing unprecedented volume in the ED, and it seemed like every single day we reached a new peak that we hadn't ever reached in the emergency department. So knowing that we really had to maintain the physical space that we were in, how were we going to care for 100 more kids a day than we would ever see during this time of the year, which is typically the busiest time. So there was a huge need to understand how long the surge was going to last, what the peak was going to be, when we were going to peak. So we really couldn't rely on historical volume from, the previous surges that we've had for just our standard respiratory volume during the fall. So we had to really quickly put something together that we can look at every single day to predict what the future was going to look like. Not just the next day, the next week, but really a month from now, 2 months from now. We were constantly working with our corporate colleagues to understand what resources we can bring into the building. We needed to understand how many nurses we were going to need. So we really wanted to look forward, not just for the ED volume. These are kids that are, again, like Brian said, showing up all at once in one space. The space didn't really increase down there, so we really need to figure out how we were going to care for hundreds more patients a day and their families, as well as what the inpatient volume was going to look like. Were we going to need to surge into new spaces? Where was that going to be? And I think looking at this every single day, updating every single day, we were able to maintain our operations and also help us to better prepare for what was coming down from a resource perspective.
I want to make a comment. Very impressed that you used the statistical model to predict day-to-day operation. In social science, we use such model, but they tend to predict more from a theoretical point of view because the variables don't lend to enough understanding of cause and effect. But here you are, you use such a model to do day-to-day operation. So I want to say it's very impressive. In particular, I know that you receive lots of pressure from the corporate office and the board, because when they look at the budget, the first thing they look at, how many nurses do we have? What are we going to do with those nurses? And so on. So you dealt with this type of contradiction very nicely.
Yeah, thank you. And that's a great point. We didn't want to talk about what could happen, what has happened in the past. We really wanted to show people what we thought was going to happen to really lend to the fact that we were not asking for extra resources just based on historical information, but based on what we thought was going to happen.
So if you had one recommendation to your colleagues throughout this country, what would you say?
I think that it's really easy to just look at what has happened the day before, the week before, and it can be very hard to plan for the future, especially when it's a triple-demic, a situation that you really haven't experienced before. But I think it really helped us to just take a step back and say, let's focus on actually understanding what the next month or two is going to look like. It was very hard to just get resources right away. So I think we really needed to prove that we had, we thought we were going to see X number of patients, a month from now. And when you really put it in the sense that like we normally see 180 patients during this time, now we're seeing 330. Like when you really show people what you think it's going to look like, it gets more attention, and I think you're able to get help a little bit quicker and earlier, before those events actually occur.
And your predictions were spot on, if I remember. You would sort of draw the prediction curve, and then each day we'd plot against it. And if I remember correctly, it was.
I think through this December, we were able to really, from October to December, we were able to really predict it well. But then we did see this like decline right in January, which usually happens after the holiday. And then it came right back up. So that was like a little bit harder of a time. But because we had predicted higher influx of patients, we were prepared for when it did pick back up.
Thank you very
And
much.
I would add, as a recommendation, don't always go to what you're comfortable with in terms of predicting. So I think a good thing that is that you see here is we use our finance team heavily. During a pandemic, I think most people wouldn't think to bring in your finance colleagues to help you sort out a predictive model, but they are used to doing financial predictions. So we didn't leave out infection control and epidemiology by any by any stretch of the imagination, but they were able to quickly, when we gave them the parameters, this is what we're looking for, very, very quickly on a day-to-day basis, put models together. So I think that's a little bit unique here. I don't think we see that much.
So we'll go on a side note for a second, but it's not a surprise because in all my years in quality, finance was always with the data. Finance always looked for validity and reliability of the information. So I used to learn a lot from my colleagues in finance, and I used that to enhance quality. So what is illustrated here is a beautiful partnership between clinical quality, operation, and nursing. This is amazing.
I think as we move forward, when this happens, when there is another chance for us to experience a surge, the technology over the last few years has improved dramatically around the use of AI, the use of neural networks, the use of other predictions that we can implement through our finance team, and the amount of data that we've collected.
AI should be a separate topic because I have a very strong opinion about AI. Only to summarize briefly, I will appreciate more to get human intervention in modeling than a computerized AI in modeling. That's how I summarize it. Thank you. Thank you very much.
The predictions, really helped us drive the resources that we were going to ask for or create. And so we managed to create dozens of inpatient beds. We were able to borrow space from the hospital the adult hospital that's connected to us. We opened an entire unit on one of their floors that they were able to decant patients off of. We were able to double up in our ICU beds. So the space that we were able to create was really a day-to-day ask to be one step ahead of where the model was sending us. We created drawings, blueprints for spaces that we never used, thankfully, because we didn't get to that point. But we were at least able to create the plan for where we were going to move next. One of the challenges that we faced with creating space was convincing the Department of Health that these spaces were safe, that these spaces contained the right equipment and staffing and structure and infrastructure to support the patients that we were treating. And so we created a document that we reviewed with the Department of Health, step by step, talking about which space we would move into next, how the patients would move there. They even asked how the ventilation, how the electricity worked in those spaces to make sure that it met the specifications of the Department of Health infrastructure team.
I was going to say, we really worked very closely with the Department of Health because we put everything in levels. And before we made that move, we made sure the Department of Health was okay with it so that they would bless it so that when we moved into those areas, they knew those patients were safe. Because they were also getting phone calls maybe from patients where they're in alternate spaces, which maybe, they didn't feel that they were comfortable in those spaces. So we had to really make sure that we partnered very closely with the Department of Health on those surge spaces.
You basically looked at level of care.
Yes, level of care.
Did you have the Joint Commission come into it?
No, we didn't have the Joint Commission come, but that's why we wanted to really partner with the Department of Health. And it was easy because this was everybody was experienced this triple-demic. It wasn't like we were doing this in a silo. So they understood the severity of the triple-demic, and they really wanted to work with us. And they really wanted us to use this as a model for New York going forward.
So, if you had to make one recommendation to the rest of the country, because in many states they don't have they have a Department of Health, but their Department of Health doesn't monitor to the same extent.
Mm-hmm.
Okay, it's much looser the relationship. What would you recommend for those states?
Whatever agency that they can work with, that they can get support, is to keep open communication with them, because they gave us some recommendations themselves. They looked at our plan. They had questions, gaps that we might have missed. So that partnering was really key. And they didn't have the resources also to come out to check on the sites. So they wanted to feel safe, that we had safety. So they wanted to ensure that we were doing the correct thing when the media or other people reached out to them. So just giving them the heads up and working with them is very important in something like this.
So you develop a trust
Yes,
between an external organization
Mm-hmm.
and your hospital.
yes.
Okay, this is good.
Yeah, other than space, we also had to consider resources such as equipment, such as wayfinding. When we're opening up new units for staff and for patients, getting to those units, traversing through the maze of the hospital can be difficult. So we out of the command center, we created some wayfinding. We created signs, some playful signs that helped parents and staff and the children feel that it wasn't an unusual place that they were visiting. This was a usual place. Here's our usual signage, consistency with our brand messaging. And this, I think this helped mentally to ensure that everyone felt comfortable and safe in that space. And then on the equipment side, right, there were a lot of babies, right, Peg? So cribs became an issue. So we had to borrow and purchase cribs on an emergency basis to fill the need within the building.
And even calling external organizations who might not have been in the critical state that we were in. So Brian's team, my team, partnered quite a bit in terms of the equipment, in terms of the wayfinding. Wayfinding was, as Brian had mentioned, was extremely important for everyone. So making sure that when the parents came in, when a caregiver came in to the front, that they knew where their child was going to be. Because, as Brian had mentioned, we were borrowing space from a birthing hospital, which is physically connected, but it does have a look and feel of a different hospital. So we did a lot of testing in terms of walking, and we used our communications director to prepare the signs that you see up there on the screen, and making sure the breadcrumbs were right. And sometimes we're like, should the arrow go this way? Which wall should you put the arrow on? And we tested it quite a bit. We also drilled response teams to make sure that the response teams knew where to go, and it just in case something happened, because that's critical. We needed to work with our front desk. So somebody came in and said, I was told my child was in CSSU, which was actually physically next door, that the front desk had a good understanding of where that was and were able to direct them. So we had lots of work on the wayfinding and the equipment during this period.
And we relied upon our adult colleagues again,
Yes.
because we knew for the 15-bedded pediatric unit that was in some adult ambulatory space, that if there was an emergency, I think we timed it, our team would take like
Yes.
3 or 4 minutes to get there. And so the adult response teams were willing to respond, just to provide hands. And I think when we drilled it, they actually came,
Yes.
because we did an
Yes.
unplanned drill, and the adult ICU staff responded. I think they were thrilled that there was nothing really wrong, but they responded, which we were
And
very
they
grateful
were,
for.
that's one of the great moments that I can recall during this experience, because we helped them a lot during COVID. We, again, not being a primarily pediatric experience, we sent our team members over to them. So their comment was, we're happy to help. They were paying it forward. So it was a good experience in the middle of everything that we were dealing with.
I think I saw on the previous slide, one that you reported to the Department of Health, at one point you had 252 patients just in the ED.
Mhm.
What would you consider at that time? So that, I mean, speaks to the volume that you had, 250 plus. So,
Yeah.
We opened up whole additional areas of the emergency department, various annexes for lower acuity patients, and we deployed some non-traditional areas of care. And I think that actually merges into the staffing, because when you're adding patients to existing units, opening new units, be they treat and release or inpatient, you need to figure out how to staff them, and the staff has to have the same expertise. So, Peg, I'll let you describe the nursing challenges, and then I can touch on the physicians.
So obviously staffing, I had mentioned that at the outset. This is a graph of our flex staff. Flex staff is our internal staffing organization that we use, and you can see that flex staff utilization where we had tremendous spend and tremendous number of individuals come here. Not everyone had pediatric experience, so I relied heavily on our education team to do just-in-time education. We brought in individuals from some of our ambulatory areas who were interested in helping. Some of our quality staff were reassigned. So we really pulled from every nook and cranny that we could. Important here is that you needed to flex down. So as using our predictive models, making sure being fiscally responsible, I had to wear my fiscal hat every day, and making sure that once this need was not there, that those resources were adjusted on an ongoing basis. So this is a slide we looked at very, very frequently, in addition to the volume and the predicted the disease predictions that we looked at on a routine basis. So making sure that we were being fiscally responsible was very important.
And we had to create additional medical teams to cover all these different units, because it's very inefficient when you have 4 patients one place, 5 patients another, as Peg taught me well. And so we ended up having to add a whole additional ICU team, a whole additional inpatient hospitalist, and we needed to increase our number of physicians seeing low acuity treat and release patients for our ED dramatically to open up these other areas of care. So everyone was in the boat rowing. And I think what makes that hard is everyone was exhausted. We were asking our ICU to create an additional call schedule, our hospitalists to do additional. We were asking residents to pick up shifts when they could on the weekends. And so I think the modeling also helped, because we knew that there would be an end in sight.
Right, exactly.
Because this is hard to sustain, and this was months. This wasn't a week.
And team members were getting sick too.
Yeah.
So, and team members' children were getting sick. Again, largely our staff is young, so having to deal with that as well. So it was a challenge.
Can you relate that back to the command center though? Did this happen through your clinical arm? Was there a labor pool going on? Like, how did you manage that?
Yeah, so during our command meetings, one of the topics was always around staffing. And so each of the areas that had to provide staffing, everyone from environmental to respiratory, had to talk about their ability to cover the new areas that were opening or cover the patients that were incoming. And for the most part, we were able to cover with existing, except when it came to places that had to have the one-on-one patient interaction. So we would then reach out to our Northfield corporate partners who have flexible staffing agencies that we can bring staff in to help us. And so this is a daily conversation with them as to how many people can you give us? What credentials do they have? Can they come now? Can they come tomorrow? So
what
that
type of training might they need
exactly
to do what we
Yeah,
need them to
community general pediatricians started
Yeah.
coming in and seeing well babies in the nursery so that the hospitalists could flip to care for children who were ill. So it was, it took a village.
And this was part of your budget. You had to pay it.
Oh,
It was not in the
It was
budget.
not in the budget.
We're still paying for it.
So,
But it's in our mission.
Yeah.
And I think that was something we were proud of. I know, Peg, when you talked to other children's hospitals,
Yes.
you didn't always hear the same thing, but we didn't turn down patients because of staffing.
No, I understand that.
And that's mission driven.
I have one more question. I know Andrea's question. During all of these scenarios, I'm sure your job changed too,
yes,
and your staff.
yes.
So you didn't do routine work anymore. You had to focus now on the crisis and how to manage the expectation, because you still have regulatory organization watching you. So can you briefly talk about that?
From a quality perspective, most of my quality nurses actually went back to the bedside. We took every area nurse that could go back to the bedside. But I think that the infrastructure that we have with our safety coaches at the bedside already, we do a lot of behavioral training and safety work, that everybody kept the target of safety in mind. We continue to try to collect the important data that we really needed. Go to the next slide. Some of the data that we developed, if you go to the next one, we needed a daily dashboard. We've quickly realized from an infection control perspective that these are 3 different infections, and we needed to monitor them daily. We couldn't really rely on one person coming in at the end of the day. So we worked with the emergency department, the lab, and finance. Kim was great to really look at all the admitted patients, which infections they had, where were we going to cohort them, where we were going to place them, could we put certain patients together. And that was a big, big challenge. And the daily dashboard from the laboratory, looking at how many patients were positive by disease and infection, was very, very important. So we had this daily dashboard developed so that we can keep abreast of the situation and make sure that we had this, even though we made the spaces, you had to take in the infectious nature of the illness. So we wanted to make sure we were keeping the patient safe. And the staff would raise their hand and call and say, we don't think this is safe. We have somebody with 2 different infections. We can't admit them there. So, we really had buy-in from the front line as well. So I think that was what was able to keep us going and monitoring the high priority metrics that we needed to.
I want you to talk about the communication.
Oh,
Okay.
Because the communication is extremely
Yes.
important. And
As you alluded to, Joseph, communicating both within the institution to our colleagues was crucially important, and then also communicating outside to the community. And so we had a number of different communication vehicles. Communications is actually part of the incident command, and so that was being run centrally. We had, as was mentioned, wayfinding and disease-specific flyers that were up. We had an email that went out weekly summarizing what had happened, what we thought was coming forward, and we had a 60% open rate, which is very high. There was locally produced podcast featuring the lead of our emergency department, and Peg really answering questions and talking about what's going on. And then we had the local and national media on site interviewing various clinical leaders about what we were seeing and predictions moving forward. So we had a full strategy around communication, and I think, as Linda was saying, that was crucial to ensuring that frontline providers and frontline staff knew what was happening and what to expect, because it was easy for us coming into the command center to know, but everyone on the front line had to know as well.
And I used the acuity dashboard in my town hall meetings. So I would just take photos of it and drop it in there, because sometimes the team members' gestalt of the experience, it mirrors what is actually happening, and sometimes it's not. So I would have staff that would say, for example, it feels like, we're getting so many flu patients, and well, not really. It might be your experience on the shift, and that is your experience, but look at how it's trending, or you're spot on. Yes, the flu is going up, COVID is coming down. So, and these were with frontline team members. So we were very, very transparent so that everybody really understood. There was a lot of fear. This, keep in mind during this time that particularly individuals, team members who had children at home, they were afraid of what was happening. It was on the news constantly. And they were being asked by their friends and family what's happening. So we had to damp down that fear and really be as transparent as we could.
I think this is great because you answered my next question. Because what you dealt with is how to control improper information, how to control biases, and it's really a big deal. Because if, like you said, if you see one problem that you experience, you can say everyone else is in the same level. It's absolutely fascinating. This repeats itself. So you had internal communication, and my question is really, and you didn't mention it, is that how did you provide information to medical staff and house staff, because you have so many residents here? What the platform, if you can briefly tell us what kind of platform you have for this information?
So I think there was a variety of ways. Number one, they were included in the emails. They were included in all the flyers. They were also, the chief residents and the residency director were very important to this process and were deeply engaged in the command center and the communication. And then it sort of it followed the pattern of the senior physicians, the residency director, chief residents, and to the house staff. We kept them very well informed because we were also asking them to do extra work. And so I think it was much easier to make the case to ask people to pick up extra shifts. We were able to say, yesterday we saw 350 patients in the emergency department. Yesterday we admitted 15 kids to the ICU. So we kept them apprised.
And we also had town hall meetings, which we used the subject matter expert, who was our infectious disease pediatrician, Dr. Lori Rubin, who really explained the viruses to the staff, because each virus is unique, it's transmitted differently, and it was very important for them to understand that. COVID is a new virus, and now we mix it with flu and RSV, it's something that we normally see, and it's getting patients sicker. And, they were concerned not only for the patients, but for themselves. How are they going to protect themselves? So that's how those town hall meetings were very well attended. We had question and answers. They would submit questions, throughout the week, and then we would answer them at the town hall meetings. So that communication, I really feel, was really crucial in this particular infectious disease surge. I mean, it would be the same if it's something else. You would want an expert in whatever disaster that you're dealing with to get that information out. Because, as you said, wrong information could take you and lead you in the wrong path.
And you utilize the existing structures,
Yes.
like medical boards,
Yes.
the performance improvement, coordinating group, etc.
Yes.
And this is important to
And then
let people know, because you have an existing structure.
Yes.
The town hall meetings you are doing because of the crisis. You don't do town hall meeting
Right.
as frequent
Right.
as when you don't have a crisis.
No, we continued to have our quality
Yeah.
meetings.
Right.
We continued to review any events that happened.
which we feel impacted our ability to maintain quality, maintain patient experience, because we didn't lose focus on that. The message from all of us was always that, these things that we do are important when our volume is down, but they're more important when our volume is up. Making sure that patients are kept safe and that they feel cared for.
And as Peg, as you were saying earlier, during COVID, a lot of regular business shut down in adult healthcare, including cancer treatment.
Yes.
And our cancer treatment did not stop. It couldn't stop for the children who were getting chemotherapy or bone marrow transplantation or whatever. So we continued to provide ambulatory and inpatient care to these highly at-risk patients and continued to manage neonates in the intensive care.
So the last portion of the discussion is about data. And we already touched upon it in many situations. I'm not going to ask if you have a dashboard. We obviously have a dashboard based on the graphs. I'm not going to ask you about pre-post because you did measure it and you cannot have a predictive modeling without understanding the pre-post, as you mentioned. So, as we go to the next slide, we have lots of measures and it's up to you if you can touch upon it. And what we see here in those graphs. So what does it really illustrate here? What do we have here? We have here a graph representing what?
Representing each case,
The trend.
the trend
This is
over
very important.
time,
The trend, and you have a benchmark.
of the infections over time.
This is why
Where
you need to have
COVID peaked, and then RSV came. So it was not all together. It happened at different time frames. If you could see the orange peak there, that peak was the COVID peak. And then that went down and we had some peaks of RSV and flu. So it was important to see that our predictions and validate that the predictive models that Kim was putting together were actually in reality what we were seeing. And actually we peaked sooner than she expected, but again, we were still prepared.
So the raw data that you have here really explains it.
Yes.
This is why you have raw data plus graphs.
Yes.
Okay, next, acuity.
Do you want to talk about the acuity dashboard?
Yeah. So the last one really highlighted who was coming in through the emergency department. In our daily meetings, it was quickly realized that we wanted to understand not just the volume of the patients that were hospitalized, but also how sick they were or what their acuity was. So we were able to get some help from our corporate colleagues for some data on specific variables that we were interested in. For example, between med-surg versus ICU, how many patients were on a mechanically ventilated, how many were on high flow. So really to understand out of the 150 patients that are hospitalized in our building, what sort of acuity do they present with? Is that going down or up based on the measures that we're seeing? And I think that it was really important to understand what the trends were in those measures, and also to make sure we had the skill mix in the building and the right resources from a respiratory perspective, knowing that maybe 50% of our patients need some sort of type of respiratory care when maybe our baseline is closer to 20%, 25% on a normal year.
I think as the last data slide,
Yes.
if we go one ahead, I think Linda and everyone's alluded to this, in spite of the fact that we were faced with this challenge, this is an example of some of our routine quality data. It's the control charts for our outcomes for falls with injury and for central line associated bloodstream infections going over the year period of July 22 through July 23. And if you look, you can see that we did not have a centerline shift. We did not have any increase in falls with injury or central line infections in spite of increased inpatient volume and increased acuity and higher usage of central lines. So I think we're proud of that because it says we were able to maintain quality of care during the trickle down.
And the last, we have 1 more minute, so who wants to talk
And
about the
then-
patient satisfaction?
Yeah, so
Family.
patient experience, family caregiver experience. So you can see here, the top, the blue is our likelihood to recommend. The other 2 lines are the nurse communication and physician communication. So you see we were doing very nicely right before the triple-demic. We did have a dip during this period of time, but we hadn't even come out of it, and you can see that we had gone back up. And although we had a dip, it didn't plummet. So this, again, we're attributing this to the focus on keeping our to as much as we could, our normal strategies alive and well, such as rounding. It was communicated, we will do nurse rounding, we will do leader rounding, we talked about executive rounding. We also used individuals in slightly creative ways to help support patients and families. For example, our concierge service, we had them round as well, and they provided things like some toiletries to families to kind of take the load off the nursing team, some refreshments. So having them do something a little bit different. We wanted people to feel cared for during this time of real uncertainty and highly acute illnesses that they were experiencing within their families.
So this is great. What you presented is a fantastic approach to crisis in healthcare, and many organizations can learn from your experience. And what I see is that this organization evolved. You are not only dealing with what you see, but you are also dealing with data. And this decision has an impact on clinician and others. So thank you very much for your participation in this program.
Thank you.
Thank you.
Thank you.
Thank you.